Good evening all to the Weekly Huddle. My name is Anoop Agrawal. I'm an interventional cardiologist at Care Hospital, Hyderabad. I'm joined by my colleague and co-host for the Huddle, Dr. Praneeth Palamuri. A lot of the attendees today, they are frequent attendees of the Huddle, so they don't need an introduction for the model. I'm gonna just briefly mention for the others who are joining us for the first time. So the Huddle is an unscripted audience level interaction where we address common clinical scenarios, research findings, amongst others. We aim to keep the discussion patient practice oriented, where we typically pick up a topic or a clinical case. And in today's session, we're going to talk about a clinical case. And we try to restrict our discussion around that. The basic premise of the Huddle is to bring our casual hallway discussions to a more organized platform like this one and share our ideas. While we do welcome science and guidelines, with the Huddle, we intend to help a physician translate established knowledge to clinical practice while taking local factors and practice patterns into account, effectively making it a little bit more pragmatic, if you will. We host this session every Wednesday. We were doing it at 7:30 p.m. earlier, and for the last few sessions, we have been doing it at 7 p.m. And we intend to have a discussion for about an hour. It is not a speaker and audience model. It is more of an interactive model where if any one of you have got any points to discuss or any questions to make, you can unmute yourself and ask your question, or you can just raise your hand and wait for your turn. So either way, it is fine. We want you to share your thoughts as much as possible because that's the whole idea of the Huddle. Now, coming to today's case, this is the first time where I'm discussing an inpatient case in the Huddle. This is our 50th session. We have been doing it for, we have done 49 sessions so far. And not a single time we discussed an inpatient case, primarily because I think that inpatient decision-making is a little bit more complicated virtually because there are a lot more variables that one takes into account. But for today's discussion, I did try to put relevant variables, and we are trying to restrict our discussion towards diuretic therapy particularly, or volume management therapy particularly, while understanding that in this particular patient, there are various other aspects of treatment that also deserves discussion, but then we won't be able to focus our discussion on a particular topic. I did invite a few of my nephrology colleagues, and I hope at some point I'll see them so that they can also share their thought process with today's discussion. So the way I typically do is I start the clinical case asking my colleague Praneeth his first impression. And once the tone gets started, then I invite other attendees for their thoughts and their decision making for this particular case. So in today's discussion, this case is about a few weeks old now. So we know what happened and everything, but I'm just going to go through the series of events. So there's a 64-year-old female. She had a myocardial infarction anterior wall about 3 years ago. It was a delayed presentation. She did undergo a PTCA for ongoing angina. At that time, her ejection fraction kind of stabilized at around 35%. She did develop left bundle later on, and with the EF of 35% at left bundle branch block, she was advised CRT-D by her treating doctor back in a different hospital where all of this was happening, which she refused. And she had been leading her life fairly well. She has diabetes, which is reasonably controlled on tablets. And she has got mild CKD with the baseline creatinine hovers around 1.3 to 1.5. She never had any problem with that. Now this time she's admitted in ICU with worsening dyspnea going on for about 2 weeks. She does admit that there was lack of compliance. She actually went to a family function outstation, and there she was a little bit non-compliant with her medications as well as with her salt and water restriction. And while after she came back, she started having this kind of discomfort, which she thought it'll get better, but it didn't get better. Finally, she came on here. In the hospital, her blood pressure is around 110s over 60s, which is what typically she ran previously, although she didn't check it at home recently. She's fluid overloaded on physical examination, but other parameters like oxygenation, respiratory status, and all this, they are relatively well maintained. On admission, her urea and creatinine were 38 and 1.4. I'm just giving you relevant findings for today's discussion. She was started on 40 milligrams of IV Lasix, and she got 2 doses since admission. The current picture that I'm telling you is 16 hours after admission, where the total 80 milligrams of Lasix got her 1.5 liters negative fluid balance. On examination, her the JVP is still up. Her leg swelling is marginally better since admission, so about 16 hours. Her blood pressure is more or less the same, hovers around low hundreds to maybe 100 and teens, something like that. Heart rate is 90s to hundreds, and it's a wide complex, consistent with left bundle. But her urea and creatinine now is 64 and 1.7. This is the next day lab, about 16 hours since the first one. So as you can see, her urea goes up from 38 to 64, and her creatinine goes up from 1.4 to 1.7. There was no clinical signs of infection. She had been tested with urine examination and ultrasound for her kidneys, and they all were reasonably fine. Chest X-ray still has got that congestive look, which was there on the day of admission. But she's maintaining oxygenation pretty well. She's requiring about 2 liters of nasal cannula oxygen, and she's doing fine. Subjective dyspnea has reduced as well. Other parameters, for the completion's sake, her ECG is left bundle, which I showed. High sensitivity troponin was checked to see if this current decompensation is triggered by ischemia. That came out to be normal, and effectively it's pretty normal for her CKD. Hemoglobin is 10.4, which is again more or less at her baseline. LFTs are normal, thyroid is okay, and a rejection fraction on echo was noted to be 35%, which is more or less similar to what she had previously. Moderate mitral regurgitation, moderate pulmonary hypertension, and echocardiogram suggestive of fluid overload, which is our clinical decision as well. So the discussion point for this particular case is, while she responded reasonably with diuretic, it did bump her creatinine up, it did bump her urea up. Clinically, she seems to be getting a little bit better than admission. But now, whether we should continue with this understanding that her renal parameters have slightly worsened. So the question is, should we continue diuretics, or should we think of something like an ultrafiltration or some sort of dialysis? If we do plan to continue diuretics, should we give her oral diuretic versus IV bolus diuretics like what she got since admission, or should we switch it to an IV infusion diuretics? And then any role of any adjunctive therapy, and this you can use at your liberty to discuss what all adjunctive therapy you may put her on for volume management. And we are talking about whether there is any role of IV nitrates or role of inotropes or anything else. So again, inpatient cases a little bit difficult to discuss offline, but let us try and see how this works out. And I'll use this session as a feedback whether I should discuss more inpatient cases in the later huddle sessions as well. So Praneeth, you can please unmute yourself, and I'm sure you got the case right, and tell us how you would go about it.
Yeah, good evening, everyone. So, congestive heart failure with the background of chronic kidney disease, patient with ischemic heart failure. So, patient needs a decongestion, whatever volume accumulated in her body needs to go out. So, diuretics, definitely yes. This patient received a diuretic. So first thing I would look at is what is her response to the diuretic that has been initiated. Patient who has who's been on a diuretic previously and who has a CKD, I expect their dose to therapeutic response may be slightly high. So I expect them to receive higher doses of diuretic to get the same diuretic response. So I would try to look at what is her baseline diuretic that she was receiving, and then try to kind of double up the dose of diuretic and see about her response to the diuretic administered. The way I look at is the amount of urine output that she is generating, and sometimes ask for this urine spot sodium, trying to look at how much is the sodium that she is excreting, and based on that try to tailor the response of the diuretic therapy. In this patient, I think she's having some diuretic response, may not be that adequate. So the question about continuing diuretic therapy, yes, I would continue diuretic therapy in her. The rise in creatinine from 1.4 to 1.7, I'm not completely concerned about this because I expect a rise in creatinine. But as long as I do not find other findings suggestive of renal dysfunction in the form of acidosis in ABG or any hyperkalemia, etc., I do not mind isolatedly looking at the increase in serum creatinine. So I would definitely continue the diuretics. Preferable mode of giving diuretic would be an intravenous rather than oral, because again in these patients who are having congestive heart failure, the absorption of the diuretic is a bit erratic because of mesenteric congestion. So I would definitely prefer an IV diuretic. Roll off between intermittent IV diuretic versus continuous IV diuretic. Though science says not much of a difference, I would go by the comfort of the my nursing staff who can give the diuretic therapy better. Because of the schedule or busy schedule that they have, I believe they are more comfortable giving IV infusion, put it up and continue to monitor where their effort is lessened and they preferred. So I prefer them to use IV diuretic continuous infusion therapy, though I believe that it doesn't make much of a difference between intermittent IV therapy versus continuous infusion. And see for the response regarding the requirement of renal replacement therapy within the first 24 hours, I believe is too early to make a call on taking a call on renal replacement therapy. I would at least wait for another day, a day or two, see for the response of diuretic therapy and her clinical condition. If the creatinine continues to increase and if the amount of diuretic response is not adequate, then I would again try to look at whether there is any possibility of diuretic resistance going on. Try to break that resistance by adding another second diuretic and try to achieve the diuretic response. And if I think that their kidneys are not giving him enough diuretic response, then would take the help of my nephrology colleague, discuss with him, and then probably consider renal replacement therapy. This is how I would approach this case. Anoop.
So Praneeth, follow-up questions. Tell us something about your spot sodium thing, how you do it, what you do it. Give us some idea.
So urine spot sodium is something which you take a random urine sample and you send it for the lab, which is done quickly, and you look at what is the amount of sodium that is being excreted in that urine. The 50 millimoles per liter is something which is set as a cutoff. If it is more than 50 millimoles per liter, which means that your diuretic resistance is adequate. If it is less than 50, which means that the diuretic response is not adequate, that excretion of sodium is inadequate. Natriuresis is not happening where the dose of diuretic is supposed to be increased.
And last thing, what is your thought of giving nitrates in these patients? What is your thought of giving inotropes in these patients?
Nitrates and inotropes. Look at inotropes. I will look at the systemic perfusion. If I feel that the distal perfusion is adequate, I would try to restrict myself trying to give inotropes. I don't want to ask the heart to work more than that sufficient. If I think the response is not adequate and if I believe it's all because of the pump dysfunction, then I would consider less likely, or my threshold to give inotropes is less in this particular situation. I would tend to give more of a increasing dose of diuretics, and if I think that this increasing dose of diuretic is not working, then I would try to consider giving them inotrope support in the form of D-vitamin to increase the contractility and probably simultaneously produce a systemic vasodilatation and increase in the improvement in the congestion.
Perfect. Thank you, Praneeth, for that initial start of the discussion. I will continue discussing about this case with my other attendees. And I'm just trying to go down the list here. Dr. Dr. Chandramukhi, if you are able to hear me, I hope you got the case. It is there on the PowerPoint as well. Could you please share your thought process, how you would manage this patient's volume status?
Thank you, Dr. Anoop. Good evening, all. This patient is having fluid overload, and we have already started her on IV diuretics, and her output is reasonably good. So she is responding to the diuretics which we have given, like IV Lasix. But still, the output is, I believe, like 1500 to 1600. So in acute decompensated heart failure, usually if the patient is dyspneic and symptomatic, then I would like to prefer IV infusion of Lasix, so that yeah, sometimes bolus doses can induce hypotension, and if we are giving IV infusion, then the dose can be monitored, and we can also monitor the BP and the hourly output. And this patient, you told that she is also having a moderate MR, and her BP is 110/60. So BP also looks reasonably good. So in this patient, because of the MR, moderate MR, I would also like to initiate, if she is still symptomatic and diuresis is not adequate, then I would also like to initiate IV nitrates, and then very cautiously I will give nitrates along with IV diuretic infusion, monitoring BP, so that if there are any signs of like hypotension, then I would stop the IV infusion of the nitrates. And also, in addition to like IV Lasix, like furosemide, I would also like, if the patient is not responding to the IV Lasix therapy, then I would like to consider other diuretic also, which may be like metolazone or a thiazide-like diuretic. And also, it is important when a patient comes with acute decompensated heart failure to look for the precipitating causes. Already it is mentioned that troponin is normal. So ischemia is not a precipitating factor, but there are other precipitating factors like drug non-compliance, anemia, which is very common in our subset of patients. So if there are any precipitating factors, then I would like to search for those factors and treat the factors, precipitating factors. Thank you.
Perfect. Thank you so much, ma'am. And I think my case description, there is one clear deficit that I can see. I directly wrote here negative fluid balance of 1.5 liter. I by no means try to mention that is the total urine output. The total urine output is more than 2 liters. I just mentioned a negative fluid balance of 1.5 liter. I probably should have mentioned total as well as negative. Certainly 1.5 liters urine output in 16 hours may not be that attractive, but if I would have written more than 2 liters, then that would have made things a little bit more different. So I'm going to go down the list. Let me ask Dr. Praveen Nagula. Dr. Praveen, I hope you got the case that we are discussing. If you could please unmute yourself and share your thought, how would you manage this patient, understanding that both urea and creatinine went up with initial diuretic dosing? Dr. Praveen. Oh, sorry, I by mistake muted you. Dr. Praveen, can you unmute yourself again, please?
Thank you, sir. Good evening, everyone. Coming to this case, what you call, I would be continuing the diuretic, sir. If there is an increasing trend, I would be repeating the serum creatinine and blood urea. If there is an increasing trend, then I would be thinking of whether to stop the diuretics or not. And regarding the mode of giving the diuretics, I would be going with IV infusion. And the adjunctive therapy, this patient is having moderate MR and she is also having an LBUB. So giving a nitrate would be beneficial considering her the borderline blood pressures. The rise in creatinine post diuretics can be still nitrates, the low dose of dobutamine along with the lot of nitrates would be beneficial for her, relieving the mesenteric congestion or the another thing. And if in case if she is still you call has not having any inadequate response, I would be adding a further dosage of another diuretic, metolazone, because post 48 hours of diuretic infusion, there could be inadequate response. The metolazone I would be adding, and if there is still an increasing trend of serum creatinine, say for example 2.4 or anything, then I would take the opinion of the nephrologist. And in this patient, whether even she has subjective dyspnea reduced, I would not rely upon the chest X-ray. I would do an bedside ultrasound to see how is the lung congestion, because the chest X-ray can still be having congestive features even the patient being normal. And echo-wise, I would be seeing the IVC response. And I would counsel the patient to undergo CRTD in this hospital settings.
Perfect. Thank you so much, Dr. Praveen. So one very basic thing that I wanted to discuss is cardiorenal syndrome. And to best of my knowledge, I don't think in the attendees we have any nephrologist here. I would really be interested in getting nephrologist opinion here. If anybody is a nephrologist I'm not able to identify, please raise your hand. I don't want to be disrespectful in any way. So one of the ideas of discussing this is that whenever we have got renal dysfunction in the setting of cardiac dysfunction, typically it is in one of the two forms. Either you have got a poor forward flow from the heart, which is a low cardiac output state, which causes kind of a pre-renal azotemia picture where kidney is slightly hypoperfused because of low cardiac output. And the hypoperfusion kind of gets worsened because of aggressive diuresis, and that leads to rise in urea and creatinine, which if you look at from the diagnostic standpoint, all the parameters would suggest a pre-renal azotemia. And that pre-renal azotemia is not really a dehydration, it's pretty much a hypoperfused kidney. On the other hand, you have got venous congestion, where that is the later stages of the heart failure, particularly happens in pretty bad heart failure situation like a stage D, where the venous congestion is so significant that kidney is getting hypoperfused now because of pretty much a traffic block, because of a traffic jam. Your venous flow is not getting that well. These patients typically have significant right-sided failure. And these patients, their renal indices actually improve. So their parameters look more intrinsic renal disease if you test the renal parameters. And once you give them diuretics, their renal parameters actually improve. Their urea creatinine actually improve because you are getting the venous congestion off. Typically, these kind of patients, they have, as I said, more right-sided symptoms, and they can have liver congestion symptoms as well in terms of abnormal labs or symptoms suggestive of hepatitis like nausea, vomiting, and whatnot. So the reason why I'm talking more academic here is because whenever we have these kind of situations where urea and creatinine is elevated, particularly when you are giving drugs and whatnot, I believe in our medication decision, we should ask ourselves which kind of renal abnormality are we dealing with? Are we dealing with a hypoperfused state, or are we dealing with a venous congestive state? Or is there a third cause, like a UTI or whatnot, or obstructive uropathy or whatnot, where renal indices are abnormal regardless of what your cardiac dynamics are? So coming back to this particular case, I think that going further from day one onwards, when we are making clinical decision on this patient, we certainly need to decide amongst ourselves what kind of problem are we dealing with this particular patient, and then the medical decision that is going to follow along it as well. So having said that, I don't want to change your overall strategy, how you would like to approach. We heard from Dr. Chandramukhi, Praneeth, and Praveen, and more or less the rationale or the strategy is more or less the same. You continue diuretic, you continue IV diuretic, whether bolus versus infusion that one can discuss about. And rather than backing off, we would like to make it more aggressive. Then the second question that also comes to my mind is, are we hurting kidney by doing this? Because if we are hurting kidney by doing this, then later on we may be able to improve the cardiac dynamics in terms of reducing congestion and whatnot, but at the cost of some renal dysfunction, so or worsening renal dysfunction. So that is another thing that we should ask ourselves. And maybe our nephrologist colleague have some insight about when to initiate more of a mechanical volume correction rather than a pharmacologic volume correction to preserve whatever kidney, whatever nephrons we have got. So that was my overall idea of why we should discuss cases like this. I'm going to continue asking other attendees for their input. So going down the list, Dr. Rajendra Thaplu, I hope I'm saying your name right. If you can hear me, can you please unmute yourself and share your thoughts about how would you volume manage this particular patient? Dr. Rajendra, your voice is breaking. Dr. Rajendra, your voice is breaking a lot.
Now, okay. I'm from.
Try again. Maybe this time it's better.
Yeah, sure.
Okay, we'll come back to you, Dr. Rajendra. Let me ask Dr. Mohammed. Dr. Mohammed, if you could unmute yourself and share your thought process about this particular case, how would you manage? Dr. Ali. Dr. Muhammad Ali, I hope you are able to hear me. If you could unmute yourself and share your thought process regarding this case. Okay, I'll keep going down the list. Dr. Santosh, if you can hear me, can you unmute yourself and discuss how would you manage the volume status of this patient?
Sir, first of all, whatever Dr. Praneeth sir and Chandramukhi ma'am has said, I agree with them. Apart from the diuretic, I will also consider arterial dilators in this patient, considering restrictive filling pattern and still congestion in the lungs with moderate MR. So I'll consider adding nitrates in this patient. First. Second, regarding the dose of diuretics, we should know what is the total amount of diuretic dose patient was using on OPD basis. If it is more than 120 or equal to 120, I would like to consider IV bolus dose rather than a continuous infusion, where considering the refractiveness to the diuretics, bolus dose will be better. If the patient dose is total dose is less than 120, then considering continuous infusion will be better in terms of whether to give IV bolus or continuous infusion. And inotropes I will not consider, sir. And the rest other treatment, I like to look into the serum iron profile of this patient. So irrespective of hemoglobin level, if patient serum iron deficiency is there, I would like to giving IV iron will improve the outcome, including mortality in these patients.
Thank you, Sandeep. Sorry, Santosh. Yeah, I agree with you regarding the iron therapy. This is one thing that is coming up. The data regarding this is coming up more and more. And we have been using it in inpatient, but now there is actually very good scientific data to suggest that iron deficiency should be corrected in patients with heart failure, and that does improve their overall outcome, both hospital stay as well as their mortality. So that is something we certainly should look into. Nitrate as an arterial vasodilator, I don't know how much robustness in that regard is. The way I think of arterial dilators are more like ACE or ARBs, or drugs like hydralazine, which are direct arterial vasodilators. Nitrates do have a role in this because they reduce preload immediately. So it does improve. It buys you time for your therapy to work. So certainly nitrate has a role, not particularly for arterial dilator though. Dr. Rajendra, you want to try and see if your network is slightly better?
Yeah, sir. Good evening. Am I audible now?
Yes, you are audible. Please go ahead.
Good evening, everybody. Excellent discussion on role of diuretics in heart failure. So I will also try to tread on the same path, giving that patient is wet and the pressures are borderline with acute decompensated heart failure and just adequate response to diuretics. I feel I will also start with diuretics. The clash between intravenous bolus versus continuous infusion is still there. I personally prefer for going intermittent boluses. I will also try to start with arterial vasodilators like hydralazine. And apart from it, I feel that initially, most of times when we admit in the routine practice, if the main component is not is venous hypertension, renal venous hypertension, as well as the hypoperfusion, the initial bump in the creatinine usually tends to settle down by day 2 or 3. So that was the point. The other points have been well discussed. If the patient is cold and tending towards hypotension, then I will consider giving inotropes. But yeah, they have a role when there's hypotension. Apart without that, I will not start them.
Perfect. Thank you so much, Dr. Rajendra, for your thought process. I think one point to highlight here is that when we are talking about cardiac dynamics, the cardiac output, systolic blood pressure is just one component of cardiac output. Systemic vascular resistance adds a lot to that. So is stroke volume and so is heart rate. So if we are looking at forward cardiac output in typical heart failure patient with severe LV dysfunction, then the surrogate of cardiac output cannot just be systolic blood pressure. Peripheral perfusion is a very good surrogate, and so is end organ perfusion, like your kidneys, like your brain or your liver or your intestines, your stomach. Peripheral organ perfusion and ways to assess that is certainly far more important than looking at just the systolic blood pressure. This is much different than us using vasopressors for pressure monitoring. So in this particular patient, I can understand the apprehension towards not going with inotropes, but in my opinion, if one has to be absolutely certain that inotrope is not required in this patient, then we need a slightly better objective assessment of what the cardiac output right now is. And if the patient is able to generate a cardiac output of 5-6 liters or so, then certainly inotrope will not help here. But just going by the systolic pressure may not be a good idea. And peripheral perfusion, while it's a good methodology, it has got its own limitations because of exam limitations and whatnot. So let us continue the discussion regarding this. And I still didn't get the answer from any of my attendees about what are we doing to the kidneys. So while we are talking about heart failure, improving heart and heart dynamics and all this, are we actually hurting kidneys by continuing to diurese while urea creatinine continues to go up? And what do we expect? Like what Dr. Rajendra said, that maybe by day 2 or day 3, we'll start seeing downtrend of creatinine with increasing diuresis. And I hope that is what ends up happening with most of the patients. But I think we do need to consider what will happen to the kidneys as well. So I'm going to continue my discussion. Let me have Dr. Shankar here. Dr. Shankar is a senior physician. Sir, give us your perspective on how do you see managing volume status of this patient?
Good evening to all. First of all, I congratulate Dr. Anoop Agrawal and Pranit Polamari for conducting the excellent weekly huddle. And this is the 50th session in this weekly huddle. Congrats for the same. So going into the index case, so she has got HFrEF is there. The LV ejection fraction is less than 35%, and she is in now acute decompensated heart failure. It is there is a hypoperfusion and a congestion is there, so it comes under profile C, cold and wet. So there are here there are both creatinine also here. The renal function is also at a low ebb, stage 3A initially. With the eGFR, it is 49 ml per minute, and later after starting diuresis, it has gone to serum creatinine 1.7 with the eGFR 36 ml per minute. Stage A2, stage 3A2, stage 3B she has gone to. So this is regarding the, so she has got both chronic kidney disease and as well as heart failure. So these two are really managing. If you want to manage heart failure, there will be some amount of worsening of the renal function will be there, as Dr. Anoop has nicely alluded to. So really it is a complex case and it is a complicated one. What we say, it is a double jeopardy or double trouble or double whammy, what we say. And not only double whammy or a double trouble here, diabetes is also added to this. So I say it is a triple trouble. So the dictum in our teaching by our seniors, teachers, that whenever we confront with chronic renal failure as well as heart failure, you give preference to the heart. Treat the heart, don't mind the kidney. I beg your pardon to the nephrologist, because if you treat the heart, if you improve the systolic function of the heart, if the congestion is gone, and if the perfusion is to the kidneys is well maintained, naturally the kidney function will improve. So that's why we should give, when we confront with this double trouble, I give importance to the heart. I don't neglect the kidney, but most of the therapies also, they are equally shared by both kidneys and as well as the heart in this case. So I treat the heart here. If the patient is with volume overload and edematous, so, and she discontinued the diuretic. The mainstay of therapy is loop diuretics. So whenever patient the patient goes into acute decompensated heart failure, or diuretics are not working, then we give 2.5 times of the total daily dose of diuretic, that loop diuretic or the Lasix or the furosemide. So 2.5 times. When the patient, if she is taking 40 milligrams a day, the total dose, then here we give 100 milligrams of IV furosemide bolus. If we don't get any diuresis, then if she is not responding to this, after 2 hours, we repeat, we double the dose. We make it to 200 milligrams IV. And suppose if she responds, we give every 6th hourly life. Otherwise, we give IV infusion at the rate of 0.5 milligrams per kg body weight per minute. We give the furosemide infusion. If she, along with the loop diuretics, additive or adjunctive therapy, as everybody has alluded to, is the vasodilator therapy. The nitroglycerin is found to be a good agent. Nitroprusside, niceretide, so many are there, but nitroglycerin commonly we use in the clinical practice. 20 micrograms per minute we give infusion, and we can increase up to 200 micrograms also. And if she, here I think that she will definitely respond to this therapy. Initially, there may be some rise in serum creatinine or the blood urea, as nephrologists will explain, because of the reduced volume, the renal blood flow naturally we expect a rise in serum creatinine because of the diuresis. So when she is resistant to this, even with the loop diuretics and vasodilator therapy, then there is no other go. We have to go for the ultrafiltration. That is the flow line, the management of a volume loaded heart failure. Here, because since she has got hyponatremia, we expect a hyponatremia because the dilutional hyponatremia will be there. So because of volume load, here I don't know the opinion of nephrologists. They will enlighten us. Tolvaptan, that is a vasopressin antagonist, 15 to 30 milligrams can be given orally for few days. This is regarding the management of heart failure. Heart failure begets chronic renal failure. If you control the heart failure, the renal function will be better. Automatically, that will be corrected with good perfusion. Thank you. One more thing I want to tell: the iron supplementation is essential here, because her hemoglobin is 10.4 and she is in CKD stage 3B. So we should order for the, as Dr. Santosh mentioned, we should order for the serum iron profile. As we do many a times in the management of heart failure, the iron sucrose or ferric carboxymaltose, we give infusion of 500 milligrams IV over a period of 20 to 30 minutes. If the serum ferritin here, serum ferritin, if it is less than 100 micrograms per liter, or if the serum ferritin is 100 to 300 micrograms per liter, along with the transferrin saturation, if it is less than 20 milligrams, the iron infusion is indicated here, and that will definitely improve both kidneys as well as the heart also. And erythropoietin also, I like to add in this case, because she is anemic. Till we get 12 grams of hemoglobin, we can safely give erythropoietin also. There is no stroke or thrombotic risk till 12 grams of hemoglobin. So erythropoietin, iron infusion, and tolvaptan. So these, along with the loop diuretics and the vasodilators. So probably the patient may not go into the stage of ultrafiltration, but if they fail, there is the choice is only ultrafiltration or hemodialysis. Thank you, one and all.
Thank you so much, sir. I think few points you highlighted. I will brief those, and then we will go to Dr. Somaraju for his thought process. So, and I will also read out some of the questions which has been put on the chat box. So let us see. Iron profile and iron therapy, I think that you alluded pretty well. You did mention about diuretics a little bit, 2.5 times the outpatient dose. Let me just, for the completion's sake, I'll tell you patients with oral versus IV diuretic, if they are on furosemide, then typically IV furosemide is 2 times potent than oral furosemide. There is no direct pharmacokinetic business. It's just rule of thumb. So 40 milligrams oral daily furosemide equals 20 milligrams IV daily furosemide. So if you have to double the dose or make it 2.5 inpatient, you can just convert the oral to IV, same dose or slightly higher. Torsemide is 1:1. So if you are converting oral to IV torsemide, and if your intention is to double the dose, then you have to make it double. The third loop diuretic, which is bumetanide, comes as Bumex. I have not used it in India. It is the most potent diuretic with 1 milligram of Bumex equals 40 milligrams of furosemide. I don't know if it is available in India, but this also works on the same mechanism. Metolazone also has been discussed, 2.5 to 5 milligrams of metolazone. Important, if you are giving oral metolazone and IV diuretic and IV loop diuretic, then oral metolazone needs to be given at least 30 to 60 minutes before the IV dosing. If you are giving IV infusion, that doesn't matter. You can give it at any time. If you are doing oral for both metolazone as well as furosemide, then you can give both the tablets at the same time. Nitrates have been discussed, sir, very elegantly. I do want to emphasize that in patients like these, having a combination of nitrate and hydralazine in the form of isolazine sometimes works better. We can even give half the dose and then slowly titrate it up. Interestingly, this drug in low EF patient typically does not produce hypotension because it improves cardiac output and that takes care of the blood pressure. So I typically have a very low threshold of starting afterload reduction therapy on this patient in the form of isolazine or ACE inhibitors or ARB, because I know they are not going to drop blood pressure if they have a low EF, particularly if they have mitral regurgitation as well. One question was brought up about indapamide. I don't think indapamide has got a role here. If you are giving loop diuretic, if you're not giving loop diuretic, then certainly you can use indapamide as one of the drug therapy. Cvp monitoring has been questioned. I do Cvp monitoring when I need to precisely know what the filling pressures are. In this patient, we already know the filling pressures are very high, so that is not the reason why I would do Cvp monitoring in this patient. But in those patients where, sometimes volume status is difficult to ascertain, and we need to be very precise of how much is the filling pressure, there Cvp has a role. Sometimes I do put Cvp pressure monitoring in these patients, particularly to get mixed venous saturation from there so that I can do a peak cardiac output calculation bedside. So my idea of doing central venous line in this patient is to enable me to do peak cardiac output, because that way I can decide on inotropic therapy in this patient. I have a very low threshold of inotrope for this patient. If I were the one managing it, I probably would start inotrope on not day 0, but maybe day 1 or day 2, particularly if I see creatinine going up. And if there is no active ischemia, no arrhythmia, I have a very low threshold of starting low dose inotrope in this patient. And I keep it for a day or 2. I don't prolong it more than that. One question is SGLT2 inhibitor as an adjunct to acute decompensated heart failure. I am not aware of its use. If any attendee can share their thought about using dapagliflozin or any SGLT2 inhibitor in the setting of acute decompensated heart failure. In chronic, we have been using it, but in acute decompensated heart failure, I'm not aware of this drug having any role. I particularly don't use it for that. One question which I have for the attendees, anybody can do the homework and share it in our WhatsApp group. The role of upfront ultrafiltration in these patients. When I was a cardiology fellow at that time, there was a negative trial published, and I hope if somebody can just look into Google and share that article with us. If I remember correctly, it probably was published somewhere around 2014, 15 or so, or maybe 13 or so. Upfront ultrafiltration versus Lasix or furosemide in this subset of patient, and it was a negative trial, which means ultrafiltration did not have any additive advantage over standard of care. So that upfront ultrafiltration is what we are discussing. Of course, bailout ultrafiltration is a standard of care that we do. Patients who get diuretic resistant, there we put ultrafiltration. There's no doubts about it. And then Praneeth asks role of MCS IABP in this patient. So mechanical circulatory support system in the form of IABP is required in those patients where forward output is low, or where I'm not able to manage afterload reduction, particularly when there is significant hypoperfusion of the organs. like if there is cold clammy feet, which is pretty much hypoperfused extremities, and if there is organ dysfunction in the form of low cardiac output in those patients, if I cannot manage with medications, or let us say this patient who had ischemia, there I cannot give inotropes, so I would go with the mechanical circulatory support as compared to inotrope in those patients. So I think these are some of the permutation combination that we use in making a decision. And as I said, that I probably would have a very low threshold of starting these patients on inotrope, because while Shankar sir very elegantly said that heart triumphs over kidneys, when I'm managing these patients, I'm equally worried about kidneys as well. And I think a little bit of inotrope gives that extra cardiac output to the kidneys, where it prevents that nephron damage, it prevents that ATN that happens with aggressive diuretic therapy in these patients. So that was some of the summary of what people have discussed and my thoughts on how I would manage this case. I'm going to go to Dr. Somaraju about his thoughts, and then we will take any questions or comments. Somaraju sir, if you could please unmute yourself.
Thank you, Anoop. I think most of the issues were already brought up. I'll say that the diastolic pressure of 60, you don't entertain giving any vasodilators in isolation. It has to be combined with inotrope plus vasodilators if you are serious about it. It will be, it will deteriorate the patient further. When you give a vasodilator in a patient whose diastolic pressure is already 60, and if the patient has a coronary artery disease, that will adversely influence it, which most of them have it. And even the kidney will suffer. And so if you want to give a vasodilator, don't give it in isolation with the diastolic pressure of 60, number one. Number two, the issues were raised whether the kidney has intrinsic disease or it is secondary to heart failure. I would like to know, I would want to see the urinary sediment myself or somebody who knows how to look at it. The urinary sediment will be an important key to understand whether the kidney is abnormal or not. And it is often ignored. And then while we do all these things that are suggested, when you give furosemide, don't give it orally. When you give, you have to give it frequently, 2 or 3 times a day. And other diuretics by their duration of action. It's extremely important. Don't do the mistake of giving furosemide oral once a day dose. It won't work. It's not enough. And then I would want to, if this the patient has intrinsic kidney disease and things are not improving further, I would not rush for further device therapy, etc. on this patient. Without talking to the family, patient, and everybody, I will seriously consider even palliative therapy for further management of this patient. I'll leave it at this.
Thank you so much, sir. I think we have about 4 or 5 minutes to take any questions, comments, any suggestions, anything about this particular case. Please raise your hand or unmute yourself if there is anything you want to suggest on how we should be managing these kind of cases.
Sir, in this case, what is the cause of worsening renal functions?
So in my opinion, it is poor cardiac output. That is my opinion. And that is why I said I have very low threshold of starting these patients on inotrope. I typically, what I do is I put them on inotrope for a day or two, and I use that 1 or 2 days to aggressively give afterload reduction therapy, either in the form of isolazine or in the form of ACE-ARB. I don't shy away from giving ACE or ARB, even if renal function is slightly deranged, because these drugs are the one which are going to help me take that inotrope back after a day or two, because now I have tied over that crisis. And the same thing I do if I put IABP in these patients. I don't sit on IABP. I use that time to give this afterload reduction therapy so that I get extra cardiac output even when I take the supportive therapy off. So in my opinion, in cases like these, more often than not, it is poor cardiac output which is causing renal dysfunction. An objective way of knowing, don't believe what people think or whatever.
Can I add something here?
Yes, sir.
Tried this balloon in a chronic heart failure type situation with this kidney function. Many times it deteriorates kidney function.
Point taken, sir. Point absolutely well taken. Yes. So anyway, what I was saying was the objective way of figuring this out, and it is not very difficult, is put a central line in there. Remember, these patients are a lot of drugs, a lot of IVs. They deserve to have some sort of good venous line. Get a central line through the neck, not through the groin. Get the tip at the RA or at least SVC RA junction. Get a mixed venous, get an arterial venous at that time, arterial oxygen at that time. Do a bedside FIC calculation. You will get a good idea of what kind of cardiac output you are dealing with, and that will give you a much better confidence, much more confidence of giving inotropic therapy on those patients. And one question is, at what point you give a call to nephro? Well, I have my own reservations. I give nephrology a call. Number one, when I think there is an intrinsic kidney disease other than infection, which I cannot treat. Or two, when I think I need help in terms of ultrafiltration. Those are the two situations where I give nephrology a call. Intrinsic renal disease or when I need their help with ultrafiltration. Those are the two things. So anyway, we'll continue maybe for 2 more minutes, 2-3 more minutes. Any other questions, comments, or suggestions from anybody?
Sir, even if you want to, you said you will add a vasodilator. So if you want to add ARNI in this patient, so typically after 24 hours of admission in this setup, considering the creatinine of 1.7, so is it wise to add ARNI or we have to wait till the creatinine settles, sir?
Okay, so Arnie, this is my personal thing, and I'm very mad with the how company has marketed this, and maybe somebody can enlighten me if I'm very harsh towards it. Initially, when Arnie came, it was not supposed to be started in the hospital. It was supposed to be started as an outpatient in a stable patient. The problem was the global adoption of Arnie was very less. So they identified, company did a marketing survey and they analyzed that the reason why patients are not started on ARNI is because they are not discharged on ARNI. They are discharged on ACE or ARB. And then after that, there is a reluctance to start ARNI as an outpatient. So they actually designed a trial to say that what happens when you start ARNI in the hospital. Remember, the target of that trial was to improve ARNI adoption as an outpatient, not to show that it works inpatient. But because it was started inpatient, companies started marketing this drug left and right, saying that you start these drugs inpatient. So in my opinion, ARNI should be started 24 hours before discharge. I don't care at what time the patient is admitted. Please do not, at least that is my personal opinion. And again, as I said, that if somebody wants to enlighten me onto this, that is fine. ARNI needs to be started 24 hours before discharge, not 24 hours after admission. You do your decongestive therapy, you do your whatever you need to do. But when you are pretty confident, when you're a good way of knowing when to start ARNI is when you have switched your IV diuretic to oral diuretic. When you have changed your IV drugs to oral, when you have shifted the patient out from ICU to a regular floor, that is a good time to start ARNI. Anything beyond this, anything before this, I think people have just caught up with the marketing hype. That is my impression. Anybody can highlight me on that. Okay, Dr. Sambasiv Rao, your hand is up. You have any questions or comment about this case? Dr. Sambasiv Rao, please unmute yourself. Sorry, we are not able to. Yeah.
Hello.
Yeah, go ahead. Go ahead, please.
Hello.
Yes, we can hear you. Dr. Rao, we can hear you. Please go ahead. Okay, looks like there is some problem with his connection.
Hello.
It is,
Yes,
yeah,
sir.
hi. Yes, we can hear you. Please go ahead. We can hear you.
Yes, it is usually there is a raise of the creatinine with the diuretics when we start increasing of IV diuretics. And then up to what level of increasing of diuretics we can safely continue the diuretics without consulting a nephrologist?
See, I don't think there is a cutoff for that. I would pretty much ask you that if you are not confident with why the creatinine is going up, I would say please consult a nephrologist at the very first scenario where the creatinine goes up. It is always better to take opinion from your colleagues rather than waiting till it becomes really bad. What I was telling you was my understanding of what happens when creatinine goes up. So if you have a fair understanding of why creatinine is going up and that you have a control on that, like what Dr. Somaraju sir said, you make sure that urine sediment is okay. You better make sure there is no infection. You better make sure there is no any interstitial nephritis. You better make sure. So if you can ensure that you don't need a nephrologist unless you need their help with either biopsies or you need their help with dialysis or whatnot. But if you don't have a confidence in why creatinine is going up, or if you don't know, many of the times I don't know why creatinine is going up. And in that case, it is okay to take their opinion. There is no problem with that. So, and there you take opinion at the very first rise in creatinine. Why to wait for 4 days? Because if they had to help you, let them help you on the very first day. Why to wait for that many days? But most of the time in cardiorenal syndrome, if you go objectively, you will be able to identify what is the cause behind. And many of the times you're able to manage that. But that is something you have to keep looking in a more objective form. That is my impression. It is 8:06. I think we should try to close it now. If anybody has got any other important questions, you can please type it in the chat box and I will try to discuss it before we close. I think Dr. Praveen has something to add. Dr. Praveen, please unmute yourself.
Sir, I have one what you call doubt because this patient is having an LBUB and say for example if we are starting a dobutamine on this patient and we have reached a dosage of 5 micrograms and considering the patient is having complete LBUB with a QRS duration of almost all 160 to 180, there will be dysynchronous, sir. So how to deal with that aspect in this patient if you keep a
Yeah, so I don't think there is any way for you to predict. So the way I would do it is I would put them on dobutamine and I won't forget about it. So when you come after 24 hours for reassessment, then you see if dobutamine is working or not. If it is not working, then there is no point continuing. Then you know the dyssynchrony is actually hurting you or tachycardia is hurting you. Because these patients, you would expect their heart rate to go up at least 10, 20 beats per minute. And if that tachycardia or dyssynchrony is hurting you, then that inotrope is not helping. If you put them on inotrope, they start getting a lot of PVCs, they start getting in atrial fibrillation. It's not helping. You have to back it off. So the reason why sorry, go ahead.
Sir, in that case, what would be the treatment modality, sir?
So, if your target is to get more forward cardiac output and reduce afterload, which is what dobutamine does or Milanon does, if your target is to do that, either you do it pharmaceutically with inotropes or you do it mechanically with an IABP or mechanical circulatory support. So if let us say you document that a patient is in poor cardiac output state by physical examination, laboratory markers, or your cardiac output assessment. If you establish that the patient has got low cardiac output and your inotropes are either not working or they're at high risk, the patient who has got paroxysmal atrial fibrillation or who has got multiple PVCs, history of VT in the past, these patients giving inotrope is not very safe. So in those patients, you rather put a mechanical device while you let your drugs work. But either way, you need to give a better cardiac output if that is the problem. If the problem is cardiac output, that will not be solved by simply diuresis. You have to get cardiac output in there. And what Somaraju sir said, if even those two don't work, at some point you have to talk palliative care in this. I know that there are at times where CRT suggestions have been made inpatient in a decompensated heart failure patient. I think, my personal opinion, I think that's a disservice to the patient. We should not do that. Inpatient, congested, no matter what is the left bundle, no matter what it is, I think doing CRT at that time is not in the best interest. You need to get them out of the congestion, make them better, then only put a CRT on this. Remember, class 4, NYHF4 heart failure is a contraindication for CRT. You don't do CRT in a class 4 heart failure. You do it in class 2 or class 3. That is how I would look at it. Okay, anything else you need to add before we close?
Sir, nothing, sir. And I would just want to congratulate because it is the 50th episode in almost all an year. Congratulations, sir, for conducting effective sessions since 50 episodes.
Thank you so much, Praveen. And we initially when we started, we didn't know how long we are going to go, but
Yes.
thankfully all of us are with us these days. So we are going on. And our 52nd session will be when we will have that so-called 1 year. And we want to do something different on 52nd session. So if you have any suggestions, anybody has got any suggestions what to do on 52nd episode, I wanted to actually do a in-person gathering of all the huddle attendees, whatever I could. That was my thought a couple of months ago. But in the COVID scenario, that I don't think is the right thing to do. So this is due on us. Whenever the COVID thing settles down, when the social meeting opens again, I would certainly invite all of you, all of the attendees, to participate in in-person dinner gathering, and I'll try to make sure that it is as interesting and as good as I can make it happen. So we'll do it at some point. That is something due. We'll work on that. In the meantime, if you have any suggestions, anybody for the 52nd session, please let us know. The discussion on these topics will continue offline on the WhatsApp group. If you have not joined the group yet, the link is there in the chat and it is there in every invite. So please join the WhatsApp group so that we continue our offline discussion for any particular topic. If nobody has anything else to add, may I ask Dr. Praneeth to give his closing comments? Praneeth, please.
Yeah. An interesting discussion. The only thing missing, I think, is a nephrologist point of view, which was missing. I think this is something which keeps on happening, the difference of opinion between cardiologist and nephrologist in terms of diuretic, one trying to save their respective organs. But most of the discussions were very valid and interesting about assessing a patient in an ICU having heart failure with organ dysfunction, the aggressiveness of doing an assessment and using the things available in the terms of putting a central line, monitoring cardiac output, use of vasopressors and inotropes depending on the cardiac output, and assessing the response to the therapies initiated in the form of urine spot, sodium output, and other parameters. The discussion on mechanical circulatory supports has also been discussed. And finally, when everything doesn't work out, trying to accept what is there and maybe giving the option of palliative therapy is very much a valid point which was brought out in this discussion. I think this probably needs some more discussion, and I think we should bring it up sometime again, maybe with a nephrologist as well. And finally, thank you everyone that we could complete 50 sessions. Special thanks to Dr. Shankar and Dr. Praveen for their wishes and congratulations. And we hope that we will be continuing these sessions many more, and definitely change the way I practice myself. And I hope we continue these things and we learn together with many more sessions which are going to come. Thank you.
Perfect. Thank you so much. And I'm also looking for volunteers who can do a summary, a very short summary of all the huddles that we have discussed so far in a Word document. Very simple, nothing fancy, just bullet points, what has been discussed, and share it on our WhatsApp group. That will be helpful for us to revise what we have discussed in the past, and also for people to refer to who couldn't join the sessions in the past. So if anybody who wants to volunteer for that, I will be very grateful. Having said that, thank you all for joining. We'll see you next Wednesday, and hopefully we'll have some format to make our 52nd episode a bit special. Thank you all. Good night, and we'll see you next time. Take care.